Hello everyone, today we are going to cover the abdomen assessment. This will consist of the bowel sounds as well as any abnormal shape in the abdomen, which could indicate fluid retention, which could indicate bowel obstruction. So we're going to go more in depth about how to do a focused abdominal assessment. Important to note is that when you're doing the abdomen assessment, we are going to change the order of our sequence. So instead of doing inspection, palpation, percussion, and auscultation, IPPA, we are going to do inspection, auscultation, palpation, then percussion. Because with the bowels, you don't want to move the bowels around when you're palpating, when you're pressing down on their stomach, on their abdomen. And that way you get more accurate results. So we're going to do inspection and then auscultation. Just with all of our assessments, remember you always want to knock on the door, okay, to provide privacy for the patient. Once you see that the patient is awake and it's acceptable to come into the room, you'll use hand hygiene, okay, hand sanitizer, okay, or wash your hands. Introduce yourself. Hello. And you can wear gloves. And then you want to provide privacy, close the door. If the patient has curtains in the room, you want to close those curtains to provide for privacy. In the lab, you have the curtains, so make sure that you use those. We will verify our patient to make sure that it is the correct patient. Hi, Ms. Bloom. How are you? I am back. I want to take a listen to your lungs. Is that all right? Okay. Let me just get this bed situated. For your abdomen assessment, you want to make sure that your patient is in a somewhat flat position, because you want to assess the abdomen for for the abdomen shape. So if the patient is able to tolerate being in a flat position, go ahead and place them in a flat position. And then also, if you need to, raise the bed, raise the height of the bed, so that way, let me make sure that I get this in a comfortable, so that way you are not hurting your back, because back injuries are the common cause of workplace injuries for nurses. All right, so I am going to put on my gloves. All right, and before we start, I would like to verify your first name and last name and date of birth. Okay, so we will double check that armband. Okay, yes, Dorothy Bloom, 52551. And allergies, do you have any allergies? No known drug allergies. All right, very good. Okay, so Ms. Bloom, today I am going to assess your abdomen, and I am going to need to pull your gown up as well as your bed covers off, okay? So that way I can see your abdomen. So first thing that we're going to do is we're going to do inspection, okay? So we are going to inspect the abdomen. You can place a pillow under the head, and you want to make sure that their arms are on the side. So, all right, so I'm just going to lower the covers just enough, because you don't want to expose your patient tremendously. Okay. Okay. So we're going to expose her just enough. To where we just see her abdomen. Okay. All right. So when you're inspecting the patient, you want to inspect the behavior. Is there any guarding? Are they sitting or are they, laying flat because it hurts to sit, which could be due to, problem in the abdomen? Is there any guarding? Like, are they holding their stomach in pain? Do they have a pillow in place as well that they're hugging to make sure that it doesn't hurt? Um, and you can do that just by, looking at the patient initially when you're talking to them. Um, you want to assess for skin characteristics, venous patterns. Do they have any striae or scarring? Striae will usually be like silverish in color. You want to look for any venous return patterns, which could be due to fluid overload, where you can see the blood vessels or varicosities in the abdomen. You want to assess the symmetry. Does it look even on both sides? The surface area, the motion, is there surface motion? Um, does Sometimes you can see peristalsis a little bit. It'll be visible as the wave-like movements in the abdomen. Okay. Um, does the patient have a peg tube, which is a feeding tube that's in the stomach? Do they have an ostomy? Ostomies are whenever they take out the colon, and we'll cover that in class. But the ostomy stoma should be pink, moist. You want to assess the color of the stoma, which should be pink. Is there any stool output? If so, what does it look like? Is it liquidy? Is it more solid, more formed? Depending on how far they cut the colon out will determine how much or what consistency the stool will be. If the stoma is dark and dusky, that is not good. You want it to be pink and moist because it has good circulation. Okay. If it's prolapsed, meaning that the stoma has fallen in through the hole, the opening that it was pulled out through. The stoma is actually the tissue, part of the colon or part of the small intestine that has been pulled out, or at least the remainder. It's been pulled out through the skin, and then that's where the stool is going to come out from. So if it's prolapsed, that means it's falling back into the hole, that the opening. So that's not good. It would need the surgeon to go back in and redo it. Okay. So you want to assess if there's any redness around the stoma, around the peg site. Okay. If there is one, the patient does not have one. And then if there's any drainage coming from that type of structure, if it's a peg or a stoma. Okay. You're also assessing the abdomen for any wounds. Does the patient did they have surgery? If so, assess that surgical site. You want to assess the abdominal muscles. So you will have the patient raise their head a little bit like they're doing a crunch. Okay. Because you want to see if there are any masses or hernias that pop out when those abdominal muscles are engaged. You want to also assess if there's any separation. Usually you can see the separation when it's a female patient and they've had pregnancies. So that muscle that separates the six pack will burst. It will rupture. So you want to see that. In some cases, other patients that are not female can have that as well. You also want to inspect and see if you see the abdominal pulsation of the aorta. So the aorta will be about 2 to 3 inches above the umbilicus. Umbilicus is the belly button. So you want to see, sometimes you'll see a little bit of pulsation. Okay. You're also assessing the shape of the abdomen, the contour. Okay. There are 4 types. The first type is flat. So Ms. Bloom has a flat contour to her abdomen. Okay. That's typically what you'll see. Sometimes some patients will have like a little bit of a rounded shape, okay, and that's normal as long as it's normal for the patient. Um, you'll have the scaphoid. So this is when the abdomen will sink in a bit and the ribs will protrude slightly. They'll stick out. Um, really slender people, very fit people will usually have a scaphoid contour because when they lay flat, their muscles sink in and then their rib cage sticks out. Another time where you're going to see this type of contour is people that are malnourished, okay? And that's just because they're malnourished. They don't have enough fat. So it's not necessarily normal in their case, but if you notice that the patient is slender, fit, then the scaphoid contour is going to be their normal. And then the last one is going to be protuberant. So protuberant is whenever the patient has a really big abdomen. It could be because of obesity. It could be because of due to fluid retention, ascites, or they're pregnant. Okay, those would be the three cases where your patient would have a protuberant abdomen shape. So we want our patient to be relaxed, okay, and you should see slow and even respirations when they're in this position when you're assessing them. Because if you notice that they're using their abdominal muscles to breathe, that's an indication that they're having breathing issues. So you would have to stop your assessment, raise the head of the bed up, and maybe give them some oxygen if that's what they need. Okay, so when we're doing our characteristics inspection of the skin of the abdomen, you're going to see that the skin color is a little bit more pale than the rest of their body, and that's normal because of the lack of sun exposure. The surface characteristics should be smooth, okay? You may see some scars, you might see some striae or fork marks. You might see a faint, fine vascular network present on the abdomen. It's usually barely visible. The umbilicus should be centralized, so you should see it at the center. You shouldn't see it to the side, because that could indicate that they might have a mass or an enlarged organ underneath, and that's why the umbilicus does not look like it's midline, okay? When you are assessing the abdomen contour, make sure that you assess from the foot of the bed and the side, the right side. Because when you're at the foot of the bed, like so, like this, you can see whether one side or the other is more raised, more enlarged than the other, and that could indicate an enlarged liver or spleen, if there is one, okay? So when you're assessing from the foot of the bed, you're checking to see those, make sure they're symmetrical. But then we're also coming to the right and assessing from the side to see what that looks like, okay? So that should be flat. You should see a horizon. So, Miss Bloom, now we are going to go ahead and listen to your lungs, okay? I'm sorry, not your lungs, your bowel sounds. So with the bowel sounds, we are going to auscultate 4 quadrants. You're always going to start on the right side, okay? You're going to have your right lower, right upper, left lower quadrants. And that is because you're following the direction of the colon. So you have your ascending colon, transverse colon, and descending colon. Your appendix is located on the right lower quadrant. Your liver is located on the right upper quadrant. The spleen is located on the left upper quadrant. And then the left lower quadrant is going to be your sigmoid, colon, and all that. Okay. So when you're listening to the bowel sounds, we're listening for gurgling sounds. Okay, you're going to hear gurgling. It's going to sound like tinkling, like there's water passing through, rumbling. That is what you should expect to find. There are 3 different types of bowel sounds that you will hear. The first one is the normoactive, which is what you expect to find with the growling, the tinkling, the just grumbling sounds. Okay. The abnormal findings would be either hypoactive or hyperactive. Hypoactive is more concerning because that means that the bowels are either blocked or maybe due to lack of circulation, maybe due to lack of innervation, maybe it's a nervous system issue. But if the bowels don't move, everything's going to stay where it is, and that'll cause blockage, which can cause an obstruction, which can cause perforation of the bowel, and that can lead to infection, peritonitis, sepsis, even death. So you always want to assess your patient's bowel sounds whenever you're doing your assessment, your daily assessment, and make sure that their bowels are moving. You always want to ask them when they had their last bowel movement. Okay, people are a little bit different. Some people go 3 times a day, some go 2, some go once a day, some go every other day. I've even had a patient that goes every 2 days. So as long as that is their normal, it's okay. But if it's something different than their normal, if something new, something acute that came up that, oh, they haven't had a bowel movement in 3 days, but they are a twice a day person, then yes, that is concerning because something is affecting their bowels moving. Factors that can affect the bowel movements are going to be medications. Okay, narcotics can affect bowel movements. It can slow them down, causes constipation. Dehydration can cause constipation. And then lack of mobility. You know, if they're very sedentary, that's going to affect their bowels moving. So it can be any number of things, okay? Have they had anything to eat or drink in the last 24 hours? If not, then there's not much for the body to digest, and therefore, you know, their bowels aren't going to move very much. Another case where you might see that the patient has hypoactive bowel sounds will be if they've had surgery, okay, or anesthesia. So typically the bowel sounds will be either absent or hypoactive. When I say hypoactive, that just means that you hear them very infrequently. Normal active bowel sounds, you hear them like every few seconds, okay? It's ongoing. Hypoactive, sometimes you have to listen for 5 whole minutes for any sounds in order to ensure that the patient does have bowel sounds and not documented as absent bowel sounds. Absent bowel sounds are not good, okay? Those are completely abnormal unless they don't have a colon. Then you might not hear those bowel sounds, okay? You should still be able to hear some because of the small intestine, but typically, you know, the abnormal or the absent bowel sounds are considered abnormal. So whenever we go to hear the bowel sounds, whenever you hear, you know, every few seconds, then you can move on to the next quadrant, okay? And so on and so on. But when you're listening to the quadrant and you don't hear anything for a few seconds, then wait for a minute, up to 5 minutes, okay? in order to hear something. If after 5 minutes you do not hear a sound, well, first of all, make sure that you have your stethoscope set to the diaphragm and not the bell. But after you verified everything, and yes, indeed, the patient does not have any bowel sounds there, then you can say that they are absent, and then you would need to inform the doctor, so that way the doctor can order further testing to ensure the patient doesn't have an obstruction. When you are auscultating, again, make sure that you clean your stethoscope with alcohol prior to using, but you are going to listen to the, let me see if I can show you. So this is what it'll look like from the top. So you're going to use the umbilicus as your midline, okay, your landmark, and you're going to divide the abdomen up into 4 sections, to 4 quadrants, okay? So this is the right lower quadrant. So I am going to position my stethoscope using the diaphragm lightly, okay, don't press too hard. So I'm going to press it lightly, and I'm going to listen for a few seconds, okay? So typically you should hear that growling, rumbling sound, okay? So once, and I always position my stethoscope kind of in the middle of that quadrant, so that way I can make sure that I'm covering all the space that I need. And then once I'm done with the right lower, I'm going to go to the right upper. It's very important for you to follow, these steps, okay, this pattern, because again, this is the flow of the colon. Okay, so once you're done on that side, then you're going to position your stethoscope here on the left upper, and then the left lower. Make sure that you remember which side the liver and which side the spleen are on, because if there is any abnormal shape to that abdomen, then you'll be able to identify which organ could be enlarged or have a mass or whatever the case might be, okay? So that way you know. And then where the appendix is. Because if the patient is complaining of right lower quadrant pain, then that could indicate that it might be the appendix, okay? So again, you would auscultate for a few seconds. However, if the bowel sounds you're not able to hear them very well, then you can listen to up to 5 minutes to ensure that you have an accurate assessment of no bowel sounds or hypoactive bowel sounds. So that way we can document that accordingly. So the other bowel sound that would be heard would be hyperactive bowel sounds. Those hyperactive bowel sounds are typically what you would hear when you're hungry, the growling, the really loud rumbling. You don't need to hear it with the stethoscope. So another type of, or another name for hyperactive bowel sounds is borborygmus. So this is a term that is used to describe the hungry growling sounds of the bowels, okay? Another reason why you might hear the stomach growling is due to incomplete digestion or consumption of certain foods, maybe foods that the patient is allergic to or intolerant of, such as lactose intolerance, malabsorption. The patient has diarrhea, you're going to hear hyperactive bowel sounds. The best time to hear bowel sounds is when the patient has just eaten, okay? When you listen to the bowel sounds and the patient just woke up, they have not eaten breakfast yet, their bowel sounds are going to be decreased. They're not going to be as active. So just make a note of that. If you do not hear any bowel sounds or they're decreased, this could indicate mechanical obstruction or paralytic ileus, which is an emergency. And sometimes if the patient has peritonitis or the bowel obstruction. So peritonitis is inflammation or infection of the abdominal cavity. So that could be because there's a perforation, or maybe if the patient has a PEG tube, that can irritate or cause infection of the peritonitis. If you have any questions at this point, please jot them down so we can review them in lab um, at the beginning of class. Another thing that you want to auscultate when you're in the abdomen is going to be the abdominal um, arteries for you want to auscultate for bruits, okay? Again, bruits are going to be the turbulent blood flow in the blood vessels. Bruits are going to be only heard in the peripheral vascular system. Murmurs are only going to be heard in the heart. They are both similar in that they are abnormal turbulent blood flow. All right, so the arteries that I am looking for, so it'll be the aorta. So you always want to use your umbilicus as your landmark. Your aorta is going to be 2 to 3 inches above the umbilicus in the epigastric region. Okay, so the epigastric region is going to be right below the rib cage. So that's where you're going to auscultate the aorta. Then you're going to auscultate the renal arteries. So the renal arteries are going to be about an inch above the umbilicus on the left and the right. Typically in a normal patient, you will not hear or be able to hear a bruit. You will not be able to hear the blood flowing through those vessels. So if you don't hear anything, please know that that is normal. Don't expect to hear anything. If you do hear anything like the swishing sound, that is abnormal. That is a bruit. B-R-U-I-T, bruit. The renal arteries are going to be on the left and the right, about 1 inch below the umbilicus. Okay, so those are going to be below the umbilicus. The iliac are going to be above the umbilicus. And then again, you have your aorta that you will be auscultating. When you auscultate for bruits, remember, you always want to start off with your diaphragm. Okay, when you're auscultating, so we'll pretend I'm auscultating, and then you will switch it off to the bell to hear those lower pitched sounds. And you will do the same with the iliac. What you could do is you can do everything with the diaphragm, hear everything with diaphragm first, and then switch to your bell and go through that same pattern. All right, so those are the renal arteries and the abdominal aorta. If you do hear bruits over the aorta, that could indicate an aneurysm, and that's why it's important to ask the patient what their history is, because if they have had or they do have a known aneurysm, then you'll know that that's expected. That's to be expected, okay? But please understand that normally the vascular sounds in these vessels are not auscultated. You will not hear anything. All right, so we are done with the auscultation piece. So now we're going to go to palpation, okay? When you are palpating the abdomen, you want to palpate gently, okay? Because if your patient is having abdominal pain, there's something going on there. You don't want to further damage or further cause harm. So when you palpate, you're going to palpate in the same pattern that we just did with the auscultation. So you always start with the right lower, then go up, right upper, left lower. When you have your patient, when you're doing palpation, you're going to have your patient bend their knees to relax the abdominal muscles. Okay, so for these purposes, we're going to say that Miss Bloom's knees are a little bit bent, but I'm not going to do that because that way we can see everything. Um, so whenever you have your patient ready to go, ask them if they have any pain or discomfort when you're palpating, because that's going to be an indicator of where the problem is. All right. When you're palpating, you can use one of two techniques. You can palpate with just one hand. Okay. Usually you're going to be using the tips of your fingers to palpate. When you're doing light palpation, you're going to depress about 1 inch or 1 centimeter, 1 inch. It's not very deep. Okay. And so then when you're, 1 centimeter. So when you're pressing down, you want to make sure that you don't hop around all over the place. You want to keep the pattern of palpating without lifting your fingers, okay? Because you don't want to miss anything in between those quadrants, all right? That's one way. The other way is going to be by it's the bimanual, using both hands. So when you use both hands, you're applying pressure with the top hand, okay? The bottom hand is just so you can feel. So all the pressure that you're exerting for palpation is going to come from the top. So I'm right-handed, so my active hand is going to be the right hand. So I'm going to press down when I'm palpating with the right hand, and the bottom hand is just there for palpation, okay, to feel. And so I am following that same pattern, asking my patient if they have any pain or tenderness or discomfort as I'm performing the palpation, okay. There was no tenderness noted from the patient's, okay, aspect. The abdominal muscles are relaxed. There were no masses noted, no herniations noted, no abnormalities noted, okay. So that's how we would describe when we document, that's how we would describe the assessment. No tenderness present, and abdominal muscles relaxed and smooth. Because if there were any masses in the muscles or herniations, you might be able to feel them, to palpate them. Again, when we're palpating, you want to assess, for instance, if the patient has an enlarged liver or an enlarged spleen, you might be able to palpate the mass, or a hardened, it'll feel a little harder when you're going over that quadrant. So that's why you want to palpate. So make sure that you describe the expected findings and abnormal findings at the palpated location, if any. Make sure you specify which quadrant you palpated that abnormal finding. So whether it was the right lower quadrant, left upper, so on and so on. The last step is going to be percussion. Percussion is typically not done by the bedside nurse, as well as deep palpation, so we're not going to cover those. But in your book, you're going to see that they talk about percussion. So what percussion refers to is basically just like we did with the respiratory, you're tapping, you're placing your opposite finger, okay, a finger or two on top of that area, and you're tapping on that nail of yours, and you're looking for resonance or that hollow sound, okay, which indicates air. If there's a mass, it's going to sound dull. Now, because we have organs here, you might hear it'll be dull. Now, whenever, this is an important test to do whenever the patient has an enlarged spleen or an obstruction that we suspect. The percussion can be done, but typically it'll be the nurse practitioner or the physician that will do percussion. But make sure to look at that in your book so that way you're familiar with it, because the provider will do percussion for the abdomen and the organs to assess the location to make sure they are in the correct location. The next section that we're going to cover is the GU, which is the genitourinary. So typically with genitourinary, the genitourinary area, we're assessing the kidneys, we're assessing their urination patterns, that they have any leaking of urine, any abdominal pain, which could be from a UTI, any painful urination, which could be from a UTI. You want to ask them if they have had any changes to their urination. Also, when you're asking them about their bowel movement, ask them if they take any medications that might affect their bowel movements. Ask them when they had their last bowel movement, how often they have bowel movements, what the bowel movement looks like, what the stool typically looks like. Is it soft? Is it hard? Is it formed? Is it not formed? Is it loose? So that's the consistency. What color is it? I don't know if most people look at their stool, but it's a good chance to see, okay, what are you eating? Typically the stool should be like a greenish, brownish color, but in some cases when there's problems with the bile, the stool will be like a light brown colored, like a pastel color. So the stool color can tell us a lot about the diet and what's going on with the patient. You can ask them if they smoke, if they drink alcohol, if for the genitourinary, do they have frequent problems with UTIs? Do they have changes in the pattern of urination? Do they have pain or burning with urination? The frequency, what's the color of the urine? Do they have urgency of urine? Like they feel like they can't wait, like, I gotta go, I gotta go. Typically, you'll see that with male patients that have BPH, benign prostatic hyperplasia, and enlarged prostate mainly. Does the color of the urine look, what does it look like? Typically with the urine, you want to use the COCA assessment, that's COCA, which stands for color, odor, consistency, and assessment. So the amount, A stands for amount. So how much are they putting out, especially if they have a Foley catheter, indwelling urinary catheter. You want to see how much urine they're putting out. Anything less than 100 an hour is concerning. Very concerning is anything less than 30 milliliters an hour. That means their kidneys are shutting down. The color, if the urine is dark amber, that could indicate liver or kidney disease. If the urine is dark yellow, that could indicate dehydration. If the urine has blood tinge to it, that could indicate that either there's bleeding internally in the ureters, in the kidneys, or other problems, the bladder. Or maybe if it's a female, maybe they're on their period, maybe they're menstruating. So in that case, you would have to ask the patient, if they are on their period. Kidney stones. If the patient has problems with kidney stones, how often, how big do they get? Do they pass? Sometimes blood in the urine could be from kidney stones. Dehydration can lead to kidney stones. Too much consumption of calcium can lead to kidney stones. Look at your book. It'll give you some pointers on which types of diets to recommend to patients with kidney stones, because there are different types of stones that can be formed depending on your diet. Like if you eat a lot of purines, such as like meat, red meat, organs, like liver, if you like eating liver. So those all, those are all byproducts of the food that can accumulate in the kidneys and cause stones to form. So that's what that means. When we're assessing the kidneys, we're doing the CVA tenderness. So when you're assessing the CVA tenderness, you would have your patient sitting up as much as possible. You're going to have them maybe turn to the side if they can't stand or sit up. And basically what you're doing is you're palpating the side of the flank. And I'm going to move us over. So this is visible to everyone. Okay. So you would have your patient make sure their arms are away. So you're going to expose the side. Okay. So the costovertebral angle is going to be right here. So right above your waist, okay, where the ribs kind of separate and they drop down, okay? So your kidneys are going to be protected by the bottom part of the rib cage, and you're going to utilize that area to assess the CVA tenderness. All right, so I have my patient positioned like so. So you would locate the 12th rib. So it'll be along there on the back, okay? And what you would do is you would put one hand over, it'll be hard to show you, one hand over, okay? And then you're gonna use your other hand and you're going to form a fist and you're gonna lightly tap over that area, okay? When you do that, if they have a kidney stone or any problem with the kidney, it's going to be very tender and they're going to scream out in pain. If they are not having any problems with their kidney, it's not even going to hurt because you have put your hand over that area and that's absorbing most of the shock. In your book, you're also going to see where they have like direct percussion of that area. But again, if they're not having any kidney stones or any kidney pain or problems, then they're not going to feel anything. It's not going to hurt. Okay. So let me see if I can get Miss Bloom here to cooperate. All right, Miss Bloom, let me just have you turn over to the side here. Okay. So we would locate the 12th rib. We'll say this is the 12th rib. So I would place my hand right over it. Okay, make sure we cover her up. Okay. I would place my hand right over it, and then I'm going to lightly tap it and ask the patient if they have any pain or discomfort. Okay. While I'm here, I can do the other side and repeat. Okay. Because again, you always want to check both sides, left and right. Okay. So Miss Bloom did not report any tenderness. So no CVA tenderness noted. Very good, Miss Bloom. All right. So in this case, we will just put our patient back. Okay. That would pretty much be what the genitourinary assessment would consist of for health assessment. Mainly doing the CVA, that'll be on your head to toe checkup that you will need to perform. And try to be systematic when you're doing your assessment. So everything that's pertinent to that region, try to do it that way. The way we teach you in class in these videos is going to be per system, but to be systematic, you want to be able to everything that's pertinent to the head, do everything that goes with the head, everything that goes with the chest, do the chest. So whenever you're listening to the lungs on the back, you could do the CVA tenderness, okay, and then the chest expansion from the back. You will get better at this. My hope with these videos is for you to be able to go back to them and watch them as many times as you want, or feel like you need to review, so that way you can understand and perfect your health assessment skills, because we want you to be successful. And please make sure to bring your questions to class so we can discuss and hopefully answer all of your questions. And I will see you soon. Thank you so much. Bye-bye. Oh, and additionally, don't forget to always put your patient back how you found them. So I am going to put my patient's bed down, okay? You always want to make sure that you put the bed in the lowest positions, the side rails up ×2 or 3, depending on how many they need. So Miss Bloom only needs the top 2. And that the call light is within reach, because we want our patient to be able to call for help if needed, okay? So the call light, and then making sure that the patient understands how to use the call light, because otherwise they're not going to be able to if they don't understand how to use it. And make sure that the bed is in lowest position for safety purposes. Always make this a habit, because you don't want your patient to fall. Our duty is to do no harm. And before you leave, you tell the patient that you'll be back, remove your gloves, and then do the hygiene and provide for privacy again, so you can close the door or the curtain, or if the patient desires to just leave the bed or the door open, that's okay too. All right.